So Dr. Lowell completed her doctoral degree in clinical psychology at the University of Central Florida. She is currently a postdoc fellow at the Yale Child Study Center in New Haven, having completed her pre-doctoral internship within the early childhood section, also at Yale. Dr. Lowell's research utilizes an infant mental health framework to examine intergenerational transmission of trauma in high-risk families, particularly those that are substance involved. And her clinical, she's a clinician as well, and her work has been influenced largely by her research and has focused on implementing relationship-oriented interventions with parents and young children who have experienced trauma. And we've asked her today to talk about their work and their findings from the Mothering from the Inside Out intervention. So welcome, Amanda, and thank you again so much for being here.
Oh, thank you. Can you see the slides okay? Am I all
we can see you and we can see the slides.
All right, great, wonderful. Well, thank you so much for having me. It's an honor. I mean, it was an unexpected treat that I'm getting to present today. So I'm really thankful for the opportunity to speak about my work with Nancy and Nancy's program, because it is really just a delight to see how well the program works and to kind of be in the position of helping mothers who are struggling in this really unique way. And to just see it work. So what I'd love to do is start by talking a bit about the background and some of the biological underpinnings that have really served to inform the treatment, and then we can talk about what the treatment looks like, and then how it's working, and all of that. All right. And okay. What I will do is start by talking about some background, and I know that this is all now familiar to you, and it is, because I know that you've been speaking the entire day about this. So we know, at least in America, at least in the United States, substance use continues to grow as a really significant public health issue, and it's
So we know that this is at least a problem that continues to grow in America, and we've seen even really recently over the course of 1 year that the rate of substance use continues to grow from about 4.7 to 6.3%. So it continues to grow and grow. And part of the problem with that is, I mean, there's lots of problems related to that, but there also is a disproportionate rate of child welfare involvement that we see with this population. And so part of the question is about how does that wind up impacting caregiving? And so there's a lot of ways that substance use winds up impacting caregiving, including parental sensitivity to infants' cues. So that's kind of when an infant just demonstrates some sort of need. Parents tend to be less sensitive to those needs or responding to them. So not only in picking up on those infant cues, but also the ways that they're responding to their infants. It impacts parental reflective functioning. Or we also call that mentalization. I know that those two terms tend to be kind of interchangeable, and we use them slightly interchangeably here throughout this discussion as well. And we'll talk more about what that is too in a little bit as well. But it also substance use impacts parental emotion regulation. It also predicts insecure parent-child attachment. And mothers are 2 times more likely to have their infant removed by child protective services as a result of their substance use. And overall, one of the more problematic pieces that I'm seeing as well lately is that mothers with substance use problems have a lot of difficulty accessing services because there's such a social stigma related to their substance use. So they have a lot of fears about being judged. And they also have, there's a lot of policies in place that make it quite difficult for women to access services. So for example, a mother might express fear that if she presents to some sort of service and is acknowledging her substance use, there's some fear that her child might be removed, for example, in addition to just kind of the more social pressures around, I don't want my doctor to be judging me. And the question then winds up being, why is parenting so impacted by substance use? And in order to understand that, we have to think a lot about the neurobiological basis of caregiving. That is where we have to just turn to science and think about, are there neural differences that are causing some of these impacts? It's not as simple necessarily as just substance use makes you a bad mom, but what are the processes that are biological in nature, that are in action, that lead to some of these difficulties on this slide right here? So we turn to science for that. And I know that you've already spent some time earlier today talking about the neurobiological consequences of substance use on development, but I'd like to speak more about how, on the flip side of things, how it impacts a mother's brain and how she responds to her infant. All right, so we looked to the neurobiological basis of caregiving, and there was a study that took non-substance using mothers. This was not related to substance use at this point, but this was just around how do we understand caregiving from a neurobiological perspective. So non-substance using mothers were sampled, and they showed these mothers pictures of their own babies and pictures of unknown babies, demonstrating happy affect, sad affect, and neutral affect. And what they found was that when you showed a mother pictures of her own baby, whether happy, neutral, or sad, that caused activation in the mother's reward centers of her brain. So these are areas of the brain that are related to oxytocin and dopamine, and it was kind of in the prefrontal cortices that we were noticing this, as well as kind of in the amygdala and the limbic region. So these are areas related to stress and reward. But essentially what happens is when a mother sees pictures of her own infant, she experiences this activation in these reward centers of the brain. And this was not the case when she viewed pictures of other infants. So behaviorally, what this looks like is when an infant provides some sort of cue of any type, that leads to a mother's releasing of endorphins and oxytocin, dopamine, all of those feel-good neurotransmitters, and lighting up in the reward centers of the brain. And what that then leads to is appropriate, responsive caregiving. And then the cycle kind of continues, and this relationship between these two bubbles here tends to be bidirectional. And so when there's oxytocin and the reward centers are activated, that leads to positive caregiving, which then winds up feeling really good. And then that releases more of those good, feel-good neurotransmitters and causes increases in activation in the reward centers of the brain. So this is what we hope it looks like. And just typical parents, this is kind of the goal. But we also know that this doesn't appear to be the case for substance-using mothers. So we were wondering, is there some sort of impairment here, a neurobiological difference here that is causing substance-using mothers to not engage in the responsive, appropriate caregiving that we see in typical mothers? So then there was another study that wound up doing a pretty similar protocol that looked at substance-using mothers only. And they showed substance-using mothers pictures of their own infants and of unknown infants. And what we would expect that kind of going on over here is the reward centers, exist in these mothers' brains, but when you show them pictures of their own infants, there is a blunted reward response. And so what that tells us is that there's kind of I guess the other piece to remember is that it was a stress and reward centers of the brain. And so instead of the stress leading to a sense of reward, there was a sense of stress that then led to a sense of craving, which we can talk about in a minute. But we also, in addition to knowing where in the brain these things are happening, we also know that there are differences in when these reactions are happening in the brain for substance-using mothers. So there was a recent study that demonstrated that tobacco and substance-using mothers were slower to recognize and structurally encode infant faces. So they were just slower to even understand, oh, there's an infant face in front of me. They were also paying more attention than non-substance-using mothers to neutral and sad faces, which makes a lot of sense when we think about the reward experienced by typical caregiving or caregiving by typical mothers who are paying attention to all types of faces, happy, sad, and neutral. And that feels good because they are paying some attention to happy faces, but substance-using mothers we saw were not really paying as much attention to happy faces. So it would be understandable that they're not experiencing a significant amount of reward by viewing infant faces. And we also saw for infant cries, this was a recent study that we did in our lab at the Child Study Center at Yale, that substance using mothers were slower to orient to infant cries. So they were not as fast as non-using mothers to even recognize that an infant was crying. And substance using mothers also showed a maladaptive pattern of paying attention to their infant's cries. So they were paying the same amount of attention to high distress cries and low distress cries. Whereas mothers who do not use substances were paying more attention adaptively to high distress cries that signify some sort of pain or danger or something much more threatening than a low distress cry or more of a fuss. So they are distinguishing between those two patterns of crying in a really healthy way, whereas substance using mothers are not. So there's lots of neurobiological underlying neurobiology and differences that are seen in substance using mothers that lead us to believe something different needs to happen in terms of their intervention. So overall, my colleagues at Yale have come up with the reward stress dysregulation model, which really just kind of shows you the cycle of how substance use and parenting works. And it starts over here with the perception of infant cues, which is related to high stress and low reward postpartum environment, which winds up leading to drug cravings, drug use and relapse. And then the drug use and relapse itself winds up kind of causing these drug-induced brain changes, which leads to impaired or different perception of infant cues, which I just described. And so it winds up being this really vicious cycle. And it's really difficult to determine which came first, the chicken or the egg. So behaviorally, what that looks like is there's an infant cue, and then a mother, instead of experiencing a reward response, there's more of a stress response, or at least a blunted reward response. But in the best case, there would be a blunted reward response. But in many cases, there's more of a stress response, which then, instead of leading to positive caregiving in order to experience more reward, they are turning to substance use. All right. So with those neurobiological bases of caregiving all considered, that is really what was used to inform the intervention that Nancy has developed at the Yale Child Study Center and in the Department of Psychiatry. And it's called Mothering from the Inside Out. So let's talk a bit about the intervention with this population. So really importantly, something to consider is that most evidence-based parenting interventions just were really not cutting it for substance-using mothers. And there's a few reasons for that. So most programs, this is for a typical population for mothers who are not using substances, they do work really well, but they're really focused on children's behavior problems. So it's a focus on how do we get this child to behave the way that we want them to behave? How do we help shape your behavior so that the child follows suit? And how do we maybe improve your relationship in the process? But it's really meant toward changing children's behavior. And there is a complete lack of consideration of parents' psychological vulnerabilities and the neurobiology underlying those vulnerabilities. And what we wind up seeing phenomenologically is that substance-using mothers exit prematurely. So it's actually quite hard to assess whether these treatments are working for them, in part at least because they're just leaving treatment early for lots of reasons. Pretend you're going to a regular child guidance clinic for parenting support. And we've seen this happen many times where mothers come to a typical child guidance clinic, but they have a substance use problem and they're really, really, really worried about someone finding out about their substance use problem and that they would call Child Protective Services. They're worried about their legal ramifications as well as the social judgment. In addition to all of the other pieces around a woman's recovery that complicate her ability to attend regular sessions for parenting. So there's lots of reasons why a different approach was needed. And the approach that was generated was called Mothering from the Inside Out. So it is the first evidence-based parenting intervention for mothers who are in substance use treatment and who are also caring for young children. And we have established efficacy. Nancy has done she's completed 2 full trials with master clinicians, and we are at the very, very, very tail end of our 3rd randomized control trial that's been NIH funded. And at this point, we are delivering the intervention with substance use counselors, which I'm excited to talk about in a little bit as well. So we have indeed established efficacy, and overall the aim is to alter all of those stress and reward neural and behavioral responses to infant cues that I had described earlier with some of those pictures of mothers looking at their infants. So really, this is what the intervention is based on. Like, how do we alter that vicious cycle? So how do we do that? That's the question. And the way that was developed, and the way that kind of after poring over a lot of research on what type of work works with this population of substance using women, the idea came about from mentalizing. So we help women regulate via the development of mentalization. And we focus especially on moments of effective arousal when mentalizing capacity has totally broken down. We'll talk more about what that looks like in a minute. So mentalization, essentially, I know I had mentioned previously, it's really akin to reflection or reflective functioning. And overall, it's the capacity to make sense of behavior in oneself and in others in terms of underlying thoughts, emotions, wishes, and intentions, which if we think back to other parenting interventions, this is really quite different. This takes it down to a different level. So instead of just aiming to alter behavior, it's really helping mothers make sense of behavior, not only in the child, but as well as themselves, and how that relates to their recovery, and what thoughts and emotions, wishes, and intentions are underneath the behavior. In 2 parties too. So that's the other piece that I think is quite important to emphasize, that we're helping parents identify and regulate emotions that become activated in themselves during different situations, particularly stressful parenting situations. And we also, so they're mentalizing for themselves as well as mentalizing for others. So helping them accurately recognize and understand young children's attachment-based emotional needs. Okay. And essentially that looks like not a curriculum. So it's not content-based. It's not a curriculum. It's not week by week, here's what we're going to talk about. But really, it's meant to foster a process so that a parent learns a skill as she's engaging in it, not as it's being taught to her. And we really tried to focus on any aspect of mentalization. So it can take a lot of different forms. So every session might look different. It might look different week to week for any given patient. It might look different patient to patient. And it's really meeting the parent where they're at around what type or what mentalizing capacity they really need to work on, or what's really hard for them in the moment. So first of all, we'd really try to help parents think about themselves and their children as though their children have a mind, because not often do they realize that their children do have minds of their own. We try to help parents remember the importance of staying inquisitive and curious, and help them make good guesses or hypotheses about mental states. And so we really try to encourage flexibility in the ways that they're thinking. So this also does relate to some of the work I know that you're doing up in Canada around executive functioning and maternal substance use. And really, it's helping parents feel comfortable making a guess based on the information that they have and trying out lots of different guesses. We help parents understand that that anybody's mental state is opaque, and we can't know it for certain because we're not mind readers, and that's okay because we're just making good guesses. We also help parents acknowledge that multiple coexisting mental states can happen all at once. So this brings in a little bit of a DBT, dialectical behavioral stance or flavor to things. So again, this also relates to flexibility, having parents think about there's not just one answer and there's lots of things that could be going on for a child or themselves, really. We also help parents notice how mental states change over time, and we mean that in a lot of different ways too. So when we say helping them understand mental states change over time, we could mean within the course of an hour. We could mean within the course of a few moments as they become more regulated. We could mean over the course of a relationship. And we could also mean over the course of a child's life because they're consistently developing and their needs change over time. All right. We also help parents make sense of how mental states work together to influence behavior, and how mental states interact with one another. And so a parent has a mental state that influences a child's mental state through the behavior that they wind up noticing in one another. We also help parents distinguish their own internal experiences from someone else's internal experience. So again, this relates back to the idea that mothers have minds of their own, and helping them recognize that their children have different minds, and that other people have different minds. So what they know isn't necessarily known by others, or experienced or felt by others. And finally, we help parents consider how their own mental states affect others' mental states, and how others' mental states might impact their own, and how that could happen through the process of mental states impacting behavior that's been observed in another person. But it can also happen, like we work really hard to help parents consider how, when they're feeling stressed, how their children wind up noticing it and experiencing it, even if we aren't talking about behaviors. Okay, so there are three main short-term goals of mothering from the inside out. Of course, the long-term goals are around fostering the parent-child relationship and increasing attachment security and reducing relapse risk and kind of breaking that cycle. But short-term, what we really aim for is to provide a positive first experience in a therapeutic relationship where the mother's thoughts and emotions are taken seriously and she feels supported and understood. One of the main reasons for that is because, at least in the clinic settings that we've worked in, and how things in the States are really established, is that women or anybody in substance use treatment doesn't necessarily have their own individual psychotherapist, which is unfortunate. And because there are so many good benefits to having the individual psychotherapy, but very often in the clinics that we're working in, at least, there's an open access model. And so a client has to come in once per month in order to continue getting their methadone dose. And that could be a group, that could be an individual kind of check-in or a treatment plan review with whatever clinician is available. And then they kind of come and go and get their bottles of methadone as needed, but aren't getting consistent psychotherapy. And so we're really trying to use a parenting intervention as a means of providing individual psychotherapy that is parent-based, and fosters a positive attachment relationship that we're hoping models some good form for the mother to then use with her child. We also hope that mothering from the inside out is used to begin a process of helping the mother make sense and thereby enhance the regulation of her own and her child's internal affective experiences. So really, it's the key is making sense of winds up being really regulating, fostering that process. And then finally, our last short-term goal is to help the mother think about her children's behavior in terms of the child's internal needs for the mother to be a secure base and to meet the child's needs, and be an emotionally stable presence for that child in terms of their attachment behavior. All right. So the treatment logistics, let me tell you a little bit about what the treatment itself looks like. I know I said it wasn't content-based or curriculum-based, but here are more of the logistical pieces outside of the treatment. And so at this moment in time, what's been tested as showing efficacy is a 12-session individual model. It's meant to be an adjunct treatment for mothers who are already in substance use treatment. And so our goal is not to focus solely on substance use treatment, but we do bring her substance use into the room if necessary and try to help her think about how her parenting and how her interactions with her children impact her sobriety or her recovery. But either way, it's meant to be an adjunct treatment for a woman who's already in her own substance use treatment. And there are several different program components. So there's 4 in total, but there's 3 really on top of the individual treatment component, which I'm going to talk in more detail about, is the individual treatment component and what that looks like. But for this program to be successful, we really do think that all 4 of these pieces need to be present. So in addition to meeting once weekly with the clients, we provide developmentally informed childcare. And so there are kind of really well-trained childcare specialists who are there in the clinic, who are able to essentially babysit the child while the mother is engaged in her individual mothering from the inside out session. And I think what's worth noting here is that the child is allowed access to the mother at any time during the session. So if the baby needs to be changed, or if the baby needs to be fed, or just needs to get their emotional cup filled, needs to visit mom, they're able to do that. So the childcare specialists, their job is not to keep the child safe in a room. Their job is to follow the child's emotional needs. And if that means visiting mom while she's in treatment, then they allow that to happen. And what winds up being really lovely about that model is that it provides some grist for the mill. It provides some really good clinical material for the therapist to then utilize in her treatment with the parent. So the therapist might kind of speak for baby or speak for the child to help the mother begin to consider what might be running through the child's mind. Or the therapist might also say, once the child has left and gotten their cup filled, the therapist might be inquisitive with the mother and say, what do you think was going on? What, she came to visit you. That's not typical. What do you think was behind that need? Or what do you think was going on for her? To then just kind of continue to carry the rest of the session. And it winds up being this really lovely model that gives us good clinical information, because the child is allowed access to the mother, but the mother still has her own space. So it's not meant to be a dyadic treatment like child parent psychotherapy, for example, but it gives her space while still holding the child in mind, and sometimes in person. The person who also provides the developmentally informed childcare also in our program has provided family-focused case management. So very oftentimes our mothers will come in and have financial difficulties or housing problems, or need to be connected to domestic violence services, or their child is having behavior problems and needs their own treatment, for example. So we have folks who are really well versed in getting these mothers connected to those services and doing warm handoffs for them too. And then the overarching idea is for there to be a non-judgmental program milieu. And I think that is, I can't emphasize that piece enough. So very often when we recruit mothers for the study or for treatment, they're a little bit skeptical at first, because we say, oh, we have a moms and kids program. And they're not so sure, because they think that we might be coming from just a child-focused lens, or from a general child guidance clinic, for example, without an understanding of addiction or recovery. And so we have to be really explicit with them that we are solely in the substance use treatment setting, and that we really get addiction, and we're here to be helpful for that. We don't judge it. And then they wind up sticking really well. So we do have a really high retention rate. We don't see the same types of poor, or the same types of high attrition rates that some of the other parenting interventions often see with this population. All right, so in order to establish efficacy, research thus far has compared mothering from the inside out to just a general psychoeducational parenting intervention, and it is a pretty good intervention. It's just not got the neurobiological vulnerabilities in mind the same way that mothering from the inside out does. So it is a really strong intervention that we developed as a strong competitor to mothering from the inside out, to really see what was going to be effective. But it's very behavioral based, and it's pamphlet based, actually. So a mother can kind of come in and ask, oh, I'm having trouble with potty training. And then a therapist has some developmental training and is able to look at a pamphlet with a mother and help walk her through how to tackle that problem. And like I had mentioned previously, at this point, it is being delivered by substance use counselors who have, they're not master clinicians. They don't have developmental training. They are folks who are boots on the ground in the substance use treatment setting, and they are now providing this intervention and really liking it. So we'll talk more about the results in a little bit. But I'd like to talk now about the focus of the mothering from the inside out sessions. And so there is a focus on the mother as well as on the child. So when we focus on the mother, we aim to have the therapist follow the mother's lead and her affect for the session focus. So there's no curriculum, and the mother is able to come in and talk about what she really needs to talk about. It's really led by her. The mother leads the therapist to a situation that she is experiencing as stressful in the moment. And we very often, very similar to the parent development interview, if you're familiar with that, which really encourages mothers to think about specific experiences that have happened really recently. And the idea there, that's kind of here too, it's considered in great detail in order to kind of get a really, really rich experience to build that mentalizing capacity that we're trying to build that skill. All right. The mother is also encouraged to consider the thoughts, feelings, and intentions of herself, as well as those of her child and of others. And finally, the mother is invited to use mentalizing strategies to make sense of those things, to make sense of her own thoughts, where they're coming from, how she got from A to B in her head, as well as how that happens with children and other people in her life, the other people that are important, her important attachment relationships. All right. We also try really hard to focus, given that it's a parenting intervention, the idea is to also focus on the child. So the child is always held in mind by the therapist. And even if the child isn't in the room, or even if mom kind of doesn't remember to keep the child in mind, the therapist that's their job, to keep the child in mind. The therapist also aims to help the mother consider the child's internal experiences, such as thoughts, feelings, intentions, all of that, and then bring them up when the timing seems appropriate. So our goal isn't to only ever talk about the child, but if the mother is talking about something that really dysregulated her, and then and the children were present, for example, or maybe even not present, at some point, the therapist, the idea is that the therapist would say, how do you think your child experiences this stress that you're under? What do you think that's like for them? To kind of help them consider the internal experience of the child. Really importantly, the child's developmental, cognitive, and emotional capacities are taken into consideration based on the child's age. So helping the mom have really realistic expectations for what the child is capable of, given where they're at. The child's emotional and relational needs are considered from an attachment perspective. So we try really hard to bring that focus in as well. And so I think most of our substance use counselors who are providing mothering from the inside out are now trained in Circle of Security as well. And so the idea behind that was not so that they would be delivering Circle of Security, but rather just to give them a primer on attachment and how that can look good and bad, and then to bring some of those concepts into these mothering from the inside out sessions. And finally, the child's individual unique temperament characteristics are also included in the way that we think about the child too, thinking about how all these children are unique. All right. So overall, we really aim to help the therapist develop what we call the mentalizing stance. And there's a few general guidelines that I'd like to go over around how we keep that mentalizing stance. And then we'll talk a little bit more about each piece of the mentalizing stance after we do this. So overall, to maintain a mentalizing stance, the focus is on the present stressors, the present emotions, the present experiences and behaviors, in addition to how past events have led to those present states of mind. And so this is not meant to be a trauma-focused treatment necessarily, but it certainly does take trauma, as well as many other past experiences, into consideration, and brings them up for the parent to say, well, I know this about you and your experiences. Do you think that that has an impact on the way that you're experiencing this now, or the way that your child is behaving now and your sensitivity to it? We also try really hard to avoid explanation and interpretation, but rather be really curious and inquisitive. And we really want to invite and encourage and support the mother's mentalizing stance. And the key is that mentalization is a skill, and we are helping the mother build it through practice in session, through that process, rather than teaching it didactically or through a curriculum. We are helping her develop that skill as a process, as she does it in session with the therapist. All right. So there's 5 components to the mentalizing stance that have shown to be really important and that we have incorporated into mothering from the inside out. And we'll go through them each one by one. So for not knowing, what we mean by that is that we acknowledge the opacity of mental states and the limitations of our insight. We don't know for certain what's in the mother's mind. And we also know that even though we can't know what's on the mother's mind, we have to help her make good guesses. We also convey that we don't know for certain what's on the mother's mind. Like, we have to make that really explicitly clear. So a therapist would say, I can't know for sure what's going on for you, but what I imagine might be happening is X, Y, or Z. But we don't want to superimpose our own thoughts or ideas on it, because we want her to be engaging in the process. We want her to be doing a little bit of work there, not just relying on what the therapist is suggesting. And finally, for not knowing, we also don't know for certain what we are thinking ourselves as therapists. And so we have to be pretty transparent about that too. Like, we can't know everything all at once. Some things are just not accessible to us either, which really humanizes us as well. All right. When we are curious and inquisitive, that is an important piece of the mentalizing stance as well. And what I mean by that is that we have to be genuinely interested in what the mother thinks, says, and experiences. We have to be curious about it. We assume that each mother's mind is unique and it works differently, and that the only way to understand it is to ask about it. So that means that we need to be openly inquisitive about it in a way that helps the mother know, oh, this person really cares and wonders about me. We also help make room for the mother to develop her own mind by inviting her to expand on her thoughts, wishes, intentions, and emotions. So not only do we show her that we are curious, but we help develop some curiosity in her to help her begin to really think about all the different ways that she got to where she is at this moment, helping her be curious and inquisitive with her own self. All right. Transparency is a really important piece of the mentalizing stance. And by that, I mean, we openly share and communicate our own mentalizing process. So this really models this process for them, and kind of lends our skill to them by saying, here's what I was thinking. Here's what was running through my head. We also acknowledge what we don't know or what we can't know. And so very often we'll say things to clients like, I don't know what was going on for you, and there's no way that I possibly could, because you are a different person from me. But here's what I might have thought you could have been experiencing based on what I know about you. Or here's what I might have been experiencing in that circumstance. Is that the same for you? But I can't know that for certain, so help me understand it. We continue to express our interest and curiosity. As you can see, these are all really interwoven. And then finally, we're genuine, authentic, and we convey that the relationship matters to us as well. For collaboration, that's an important piece of the mentalizing stance as well. And by that, this is an interesting concept. By that, we sit side by side and we help the mother consider together with us what's on the mother's mind. And so the metaphor that Nancy really often likes to use is that it's like watching a movie together. The therapist and the client, it's like they're watching a movie together, and the client's job is to kind of project it onto the screen so that the therapist and the client can watch it together and make sense of it together. All right. The collaboration that happens in therapy is a product of a reciprocal process too. So it's not just one-sided of one person telling somebody else what the facts of here's how to be a parent. And it's not just the client saying, here's what it's like for me, and then having a therapist not be able to contribute. It's really a collaborative reciprocal process. And finally, we attend to what the mother is doing and thinking and what the therapist is doing and thinking in session. All right. And finally, one of the final pieces of the mentalizing stance is holding the child in mind. So I had mentioned this previously, but we hold the child in mind even when the child is not the focus of discussion. We hold the child in mind even when the mother does not. When the timing seems appropriate, then we'll ask about the child's experience and help build that capacity in mom. And moving on to this, what I'd like to talk about really briefly too is what research has shown. We've done some component analyses around the active ingredients of mothering from the inside out. And so what we found is that there are 4 really, really, really key pieces that it's important to maintain fidelity with. And so we had rated all of these different areas of fidelity, and these were the 4 that mattered and that were responsible for the treatment effects of mothering from the inside out. So first is helping to foster the therapeutic alliance through the mentalization stance. Second is helping the mother mentalize. I'm kind of going around clockwise. So that's this one. And then the second one is fostering the mother's self-focused reflective functioning, which really means helping the mother mentalize for herself. Next is helping mother mentalize for her child and for other people, reflecting on what their experiences, how they're experiencing things. And then finally, using attachment-based developmental guidance to inform how the parent is able to mentalize for her child and mentalize for herself. All right. So you might be wondering what that actually looks like. So I have a few slides that show what a therapist might say in certain given circumstances or based on what a client brings to session. So this is an example of what an opening session might be. This might be how a clinician or a therapist explains how mothering from the inside out works or orients the person to treatment. So she says, each week we'll have a chance to talk about the stresses that you're experiencing as a mom. We think it can be helpful to try to understand what's going through your mind and your daughter's when you're getting really frustrated with her. So we'll look at those situations together to figure out how you got to the point of such aggravation. We think it's really helpful to understand what's going on and also to help you decide how you want to respond to her because there's a choice there. We also want to think about what's going on for her in terms of her development in order to understand and make sense of her challenging behavior. So I can really give you tips about how to handle challenging situations. That's fine. We can think about those things together. But I really do think that you're the expert who knows the most about your relationship with your child. So my job is to really help you make sense of it rather than to tell you what to do. So then with that in mind, a client might say something along these lines. So this is kind of an example of things we often hear at the very start of treatment, at least. So my daughter, Annie, she's getting an attitude and she doesn't listen. And this morning we had to get to the clinic before it closed. And I tried to dress her, but she just wouldn't have it. And she wanted to play with her trucks. So I said, Annie, you're going to get a spanking if you keep this up. And I know that she's just doing it to annoy me. She knew I was in a rush and did this on purpose. So then a clinician might say, I wonder if you were really worried about missing your medication. Is that right? Because previously she had said, this morning we had to get to the clinic before it closed. And she says, yeah, if I don't get medicated, I'll start to feel sick. And then the therapist says, well, let's think a little bit more about that. Let's think about what was going through your mind. Would that be okay? And it sounds like you were really frustrated. Do I have that right? What was going through your mind? And the client might say something like, yeah, I was really frustrated. If I don't get to the clinic on time, I won't get medicated. And she knows that. So then it's the therapist's job to then say something along the lines of, and you wanted Annie to cooperate and understand what was going on for you and what was worrying you. Do you think that she, or what do you think that she was thinking or feeling? What do you imagine was going on for her? And then she might say something like, I don't know, she's just a baby. I guess she just wants to play. She doesn't understand. And then that becomes the therapist's job to then say, oh, well, can you say more about that? What do you think she doesn't understand? And what do you think is so meaningful about play right now for her? And so as you can see there's some kind of developmental guidance and going on in this discussion right here. And so we've gotten from a place of having the mother not mentalizing by saying, I know for certain that my child just is doing this to bother me. She's doing this on purpose, to a more understanding place that is far more regulated and less negative by being able to say, she's just a baby. She doesn't understand. Play is really important to her because she's 5 years old, for example, and play is how children interact with the world and kind of it goes on from there. All right. So that's kind of what the treatment looks like. I know it's a very quick and dirty version of being able to explain what it looks like, and I hope it's made sense to you. But the good news is that we are getting really good results. And so in order to determine the efficacy of the treatment, what we've done is compared pre- and post-treatment assessments of the mother's characteristics, the relationship characteristics, and the child's characteristics. So first of all, and some of that is through self-report, and some of that is through observation, and some of that is through kind of medical records. And so the curiosity box paradigm is what we used in order to assess maternal negative emotionality, which really just means how is she positive or negative in her interactions with her child? And we saw that so mothering from the inside out is blue, which is these two columns here. And we saw that from pre-treatment to post-treatment, mother's negative emotionality decreased after participating in mothering from the inside out. So she was less likely to be negative with her child in those interactions. On the Beck Depression Inventory, between pre-treatment and post-treatment, we also saw a significant decrease in mother's depression after completing mothering from the inside out. At follow-up, individuals who had completed mothering from the inside out showed significantly less relapse risk compared to mothers who had participated in psychoeducational parenting. For this one, dyadic reciprocity refers to the back and forth of mothers and children in their interactions. And so we did not see an improvement necessarily for mothers who had participated in mothering from the inside out. But it did seem that mothering from the inside out was protective in that mothers who participated in psychoeducational parenting showed a decrease or a worsening in their dyadic reciprocity. So mothering from the inside out prevented that drop off from happening, which was good. All right, so reflective functioning is measured via the parent development interview is certainly one of the main targets that we're trying to address in this treatment. And we did see that between pre-treatment and post-treatment, mothers who participated in mothering from the inside out showed an increase in their mentalization skills or their reflective functioning, whereas mothers who did psychoeducational parenting did not. And then with regard to the child, this trickles down to the child as well. So for the children, we saw that there was significantly less child withdrawal during their interaction. So the child was much more engaged with parents following mothering from the inside out, whereas mothers who participated in psychoeducational parenting actually had an increase in children's withdrawal behaviors. And finally, which I think is one of the most exciting pieces, is that we are showing an improvement in attachment security. So this graph is a little bit different because it is only dyads who were in mothering from the inside out. This is not a comparison, but we saw that between baseline and follow-up, the percentage of children who were classified as securely attached increased, whereas the percentage of children classified as insecure decreased following intervention with mothering from the inside out. All right. So in terms of the future directions, we are so delighted by the positive results that we've gotten, and we're in no means done. We are certainly kind of in the still early stages of being able to get this rolled out, because we see how well it works. We really want to bring it to scale. So that is certainly the next step. And what that involves is we're hoping to be able to train the deliverers, kind of the therapists who were providing the intervention. We are wanting to train them to be trainers so that they can then bring it into the substance use treatment setting and have many more people trained in the model to deliver the intervention and really have a milieu that takes kind of attachment and trauma and mentalization really into consideration, so that the milieu holds the mentalizing stance, if you will. And then also our next step involves integrating mothering from the inside out into the substance use treatment setting. And so our next grant that we have submitted is not only to train the trainers, but also to complete some qualitative analysis in order to determine the best ways to integrate the treatment into the setting, the substance use treatment setting, by speaking with counselors and stakeholders, getting their input, seeing what is difficult, and then kind of understanding those barriers so that we can better address them. All right, so I have a few conclusions as our time comes to an end. And essentially, I think that what we've learned from Mothering from the Inside Out and our findings is that it's important to, and this kind of goes, I guess, beyond not just our clinic or our treatment program, but I would encourage kind of all of the folks in this room to take these things into consideration. And these are really just good takeaway points for anybody working with this population. So really, first of all, try to adopt a not knowing stance and really give parents the room to develop their minds in relation to their children. And then their changes in parenting will follow, we promise. All right. It's so important to encourage and entrust parents to be curious and inquisitive and to wonder about their children's behavioral cues and developmental tasks and internal experiences. Their children will experience themselves held in the mind of the parent, which helps a healthy sense of growth and helps build their healthy relationship. And finally, it's so important to learn to tolerize and empathize with parents' strong emotions about parenting. If they can mentalize these emotions with your help, they can also regulate them and have room in their minds for their children's big emotions and attachment needs. And so with all of those things in mind, we're seeing that it really does work. And the hope is that this approach can really be spread far and wide. I want to thank you for your time. I want to thank Nancy for having me help deliver this. And thank you all for listening and working on behalf of this population, because we can really see it's such an important problem to address. So thank you all so much.
Thanks, Amanda.